Okay, great. Well, good afternoon, everyone, and my name is John Steinberg. I am Assistant Professor in the Department of Orthopaedics, working under the Podiatry service with Dr. Harkless. We have a very forward-looking and aggressive service as far as podiatry is concerned in this country at the University of Texas, and a very well-published group. I am a new member of the faculty. I have joined the faculty just approximately a year ago, just a little bit less than a year ago, following my completion of a diabetic foot fellowship here at San Antonio. So certainly very honored by Lily having asked me to speak today, and I hope to offer you some information today in the area of geriatric foot concerns. Looking first at a little bit of lighthearted humor in light of our recent and in San Antonio, matter of fact, very recent healthcare layoffs. I think it certainly is nice that our work environment to be able to take a little break here and look at some academia and take a step back and refocus on just what it is that we're here to do. This is a little comic relief photo of my new office that Dr. Harkless has installed for me, and alleviates any further breaks from my workday anymore, which I think would resemble some of the rest of us in healthcare. So a bit off color for my first slide, but I thought we'd lighten things up just a bit. The geriatric population, as we well know, is certainly growing in this country. By the year 2030, we know that 1 in 4 of our patients will be 65 years or older. Of these individuals, we know that a large percentage of them, in some statistics upwards of 1 in 3, will indeed have the disease of diabetes. In San Antonio and Texas, of course, we're very focused on diabetes, and our podiatric clinic is located at the Texas Diabetes Institute, which we'll speak about in a few moments. So part of my talk, in certainly very strong relation to the geriatric population, is going to be related to diabetes, something that we deal with certainly on a daily basis here in San Antonio. The increased prevalence of older Americans, certainly we know that we have a more active population. A population that is more active into their latter years, and a population that we know is going to encounter a higher level of pathology to their lower extremities, simply from the fact that we're requiring so much of these feet and legs as opposed to previous years in the geriatric years. The American Podiatric Medical Association recently came out with a figure that states that by the age of 50, the typical American will have walked or run 75,000 miles. And this, the first thing that comes to my mind when we talk about this figure of 75,000 miles is what type of shoes and what type of protection and what type of surface were these miles on. And that's of great concern to us in the clinic on a daily basis. When we see our patients come in, it seems like such a silly thing to come to a podiatrist and someone who's done 4 years of medical school and 4 years of residency and who knows how many years of practice, and have them tell you that you need to change your shoe gear. But this is something that we see on a daily basis, and it includes our geriatric population, wherein these individuals are just not focused and not aware of the shoe gear. And I know myself sometimes I feel self-conscious in having someone leave my clinic with simply the recommendation that they change their shoe gear, and of course we give them specific examples of what to change to depending on their pathology. But this is a big part of it, and when we look at sports and activities in high school sports where we talk about equipment, when we look at walking and jogging, the only piece of equipment that we really ask of for our body is a good pair of shoes. So it's certainly something that we ask our patients to make some sort of investment in. Foot complaints are common and often lead to a limitation of mobility and ambulation. The topic here being that certainly pathology that can be expressed in the lower extremity is very broad, and there's a very large number of things that can go wrong with your foot. And I know that when discussing the profession of podiatry, a lot of times people wonder, well, how much is there to do with someone's foot and what really goes wrong? But it's amazing, and we'll go into some of those pathologies in a few moments. Certainly, as we're going to talk about some more as well with our diabetic population, looking at these problematic items of diabetes, particularly the ulceration and amputation rate amongst these patients. We're going to breeze into our UT diabetic wound classification once we look at some of the general pathology that we find in our geriatric population. And then we'll also look at our risk classification system, which is addressed at a categorized and a bit regimented approach to the diabetic foot, which oftentimes had no direct or clear treatment initiative in previous years. Looking specifically now at some of the pathology that we see, we'll touch first on some dermatology. And looking at some of the nail pathology, this is certainly something that is very common in the podiatry clinic. And as you can see, the nail is thickened, it's yellowed, is dystrophic, and this seems like a very simple, more of just a cosmetic type of problem. But number one, these patients are not able to trim these nails. When you think about the instruments that you have at home for self-care, they certainly don't have anything that's going to typically address this type of a nail. And oftentimes it's dangerous for these patients to trim their own nails in the situation of perhaps some partial blindness or total blindness and limited mobility, particularly to their hips. So although it's not a very glamorous part of podiatry, routine foot care, nail care is certainly a very important part of podiatry, and something that there really is no other area within our healthcare system that is addressed, and this is certainly very much an influence for our geriatric population. When we look at some of the other slides here, the first being just the onychomycosis that we showed in the previous picture, onychogryphosis being just a generalized dystrophic nail, a hypertrophic thickened nail that may be without perhaps actually any fungal growth. When we look then at paronychia, we can certainly see here this is the inflamed erythematous nail border with oftentimes the incurvated nail that will have a tendency for that type of infection or ingrowth. Here you can see someone who has this affecting bilateral borders and just has become a chronic process. This is someone who had this presentation for approximately 6 months before coming into our clinic. This is oftentimes an ingrown toenail we don't think of as being a severe pathology, but when we look at oftentimes a geriatric patient who may have some loss of sensation, does not have perhaps the best in home care, and letting this type of situation go for 6 months can certainly lead to osteomyelitis, and that's something that we commonly go ahead and x-ray these patients should it be of duration more than 2 months to rule out osteomyelitis. Again, another slide showing nail pathology. This looking more at like a pincer type of nail, as we hear about in the literature, and this just being a severe version of an incurvated or onychocryptotic nail, and certainly predisposed to ingrowing and infection. And this you can see some treatment for that, wherein we very commonly on a daily basis perform in our clinic a phenol and alcohol matrixectomy, wherein we, under local anesthetic with a digital block of simply 5 to 6 cc's of lidocaine, we go ahead and avulse these individual nail borders. We then treat them with some phenol solution, irrigate that out with some alcohol, and these nails have about a 90% chance of no regrowth to those affected borders. Certainly we do face in the geriatric population some level of neglect. Not all nails are pathologic, but some of them just are simply uncared for, and here you can see in this individual a very, what would seem to us just trivial type of problem, but this individual is prone to ulceration and infection, and certainly is a problem even for shoe gear wearing, and this is just unfortunate that these type of things should go without care. I put this several clinical pictures in here, not to talk too much about toenails today, but to look at some of the historical treatment of nail pathology. If you look closely at this individual, it's a bit difficult to see, but this person has had distal cymes amputations of each of the lesser 4 digits and a total nail ablation of the hallux digit as well. So a bit aggressive compared to today's standards to do distal amputations of each of the digits for problematic nails, but something that historically certainly was done. Then when we move to the right here, we can see this is perhaps now moving into our current treatment more for onychomycosis, where we deal with this nail fungus by first culturing it, identifying that this is indeed a fungal nature. Usually they're fairly self-evident that they are fungal. And then we go ahead and treat this with PO medications, of which the 2 key are Lamisil and Sporanox. And as you can see in this individual, a good clear border of the nail growth as opposed to this being the fungal aspect. This treatment lasts for 3 months. Is a once daily tablet, and you can see the fungus nail compared to now the nice fresh nail growing out after 2 months of treatment. And then if we move to the lower photo, as you can see here, again showing the clearing nail border. This is a site of a previous phenol matrixectomy where the total nail was removed, whereas the second toe here you can see now with our more progressive treatment looking at medically treating this disease rather than surgically or simply debriding it every 3 months in the office. So we're trying to get a bit more progressive about that, and if we can return these nails to a normal state, then the patients certainly can provide their own level of self-care. some skin pathology, when we look here now at hyperkeratosis, or simply thickening of the plantar skin, this is oftentimes due to focal areas of pressure or friction. We find that a lot of these geriatric patients in their poor shoe gear with shear forces with every step that they take, it may not even be that there's any focal pressure points, but oftentimes it's just a shear force from a poorly fitting shoe or a poorly designed shoe. This individual, as you can see, has what we would call a porokeratosis to this area, and then you can see more under the hallux is more, you can see how this is a callus that has a bit of a lip to it and is curving off to the side of the foot. This is more from friction or shear force that we talk about in this area. Treatments for this type of skin pathology, generally we will debride this, we will accommodate their insole so that we can take some of the pressure off of this area and load it onto this area. So if we build up this portion of their shoe insole, we'll take some of the pressure off of here, and then we just try and address this as simply and as directly as we can, very rarely doing surgery in the geriatric population for any type of callus formation. Continuing on now with skin pathology, this is a rather aggressive wart formation that you can see at the distal aspect of a individual's hallux, and certainly this verruca plantaris, or the human papillomavirus, we know is of that viral origin. Generally we find this on the plantar skin. This digital presentation is certainly not a typical presentation for us in the podiatry clinic, and it's more common found in the teenage years for us than in the geriatric age population, but it's certainly something that we see amongst all ages. Our treatment generally for plantar verruca is one of many. This is an entity that has been around forever and has been treated forever, and if you look at the textbook listings of treatment, you'll see that there really are about 30, and that's probably conservative. Everything ranging from debridement to chemical therapy with salicylic acid, to surgical excision, to cryotherapy, to one of the newer trivial anecdotal type treatments in the literature is the use of cimetidine at 25 to 40 milligrams per kilogram per day, so a rather high dosing of Tagamet that has found some benefit in some of these mosaic type warts where there's not something you can address to a focal area, but someone who has a very large distribution of these plantar warts. And in the literature you'll see it documented for psychotherapy for wart treatment. So you can see it's obviously something we've struggled with for many, many years, and is something that we oftentimes see spontaneous resolution and recurrence despite our best treatment efforts. Looking now at another form of skin pathology, as we can see here, the tinea pedis, or athlete's foot, very, very common, something that we see on a routine basis in our patients. But when we get into the geriatric population with a compromised immune system, when we get into the diabetic population in particular, we're looking at someone who does not have the ability to keep their skin intact during this fungal infection, and that's where we get into the problem of a secondary bacterial infection, oftentimes gram-negative, just because of the area that we're working in, that then becomes a true limb-threatening problem from a simple entity of athlete's foot. And here you can see interdigitally here spreading the toes apart, this being the beginnings of tinea pedis, may be symptomatic, may be asymptomatic, but this macerated white moist skin needs to be dealt with before it becomes a compromise and a break in the skin. So oftentimes we'll use something as simple as some lamb's wool, something to space those toes apart and prevent that maceration becoming a problem. We oftentimes say a moccasin distribution for the tinea pedis. So here you can see a bit of a differentiation with this rough, irregular red line, and this person complaining of itching throughout the entire plantar aspect of their foot. We're becoming more aggressive in treating tinea pedis as well, and we have found some success with using the same antifungal Lamisil and Sporanox that we use for the nail fungus in this skin fungus, but just do it for a simple 2-week course of once-a-day Lamisil. And that has been very helpful for us, and in addition certainly the continuing topical medications as well as the creams and solutions that are available to us even over the counter. Here you can see, as we talked about how bad this can get, here you can see a gentleman actually who I just saw in the emergency room within the past 2 weeks who presented twice in a row for this problem as it continued to worsen. And we finally saw this gentleman and identified this as really a very aggressive tinea pedis. And the phone call from the nurses was, oh, we have a we have a foot here that's just infected everywhere and it's got an ulcer everywhere. So there's going to be a surgery for you all that needs to be done right away. And really this is certainly, in some levels, has a component of limb threatening to it, but this is really a tinea pedis that needs to be aggressively treated. This is a case where we'll use the PO, Lamisil. We'll dose that for 2 weeks. This person needs betadine soap sponge between each of their digits to help dry this out, and they need to control their environment as well. So this is something that is rather simple but needs to be treated aggressively. Looking at the microscopic level here of tinea pedis, not something terribly exciting to talk about here on this Friday afternoon, but just looking at something as simple as a KOH prep when we're in the clinic in the afternoon and we're struggling as to, is this a dermatitis, is this an eczematous dermatitis, is this some type of a contact irritation, what is this redness and itching that the person's having on their foot? We take the skin scraping, we put a few drops of potassium hydroxide on that, give it a few moments to cure, place it under the microscope, and we can rule that out if we see these hyphae, or pseudo-hyphae, that this is indeed a tinea pedis versus seeing simply some dried keratinocytes and other miscellaneous objects is going to give us a very strong likelihood to rule out a fungal infection of the skin. Looking here at eczematous dermatitis, certainly we could talk all afternoon on dermatologic matters. I just picked a few here to discuss, but here you can see differentiating. This is more of a dorsal type infection, the tinea pedis being more of a plantar infection, and this dermatitis here is showing just a bright redness, not a whole lot of itching a lot of times from this, and involving most often for us the digits in this form of dermatitis. Moving on now to some of the orthopedic or structural deformities that we see in these individuals, and again, just going to touch on a few of those so that we have time still to talk about some of the diabetic concerns. When we look at the forefoot deformities, we're talking most often about bunions and hammer toes. And the bunion deformity or hallux abductovalgus is certainly a rather complex entity that involves much more than these patients just forming an exostosis or bunion bump on the medial aspect of their toe. This involves an increase in the intermetatarsal angle, wherein the first and second metatarsals are no longer parallel, but they're forming a large V. And this is why many of the former bunion surgeries failed, because they simply addressed the bump, or they did not fully address the intermetatarsal angle. So now most of our procedures are targeted at actually correcting this intermetatarsal angle, and oftentimes even coming back to the metatarsal cuneiform joint, wherein we actually fuse this joint at the true apex of the deformity and prevent this hypermobility throughout the foot. So as you can see, in this case, the bunion is actually relating to the lesser digits, wherein this is taking up the weight-bearing space for the lesser toes and is causing this digital contracture and now even overlapping of the second and third toes. And this is certainly a high predilection for ulceration, pain, and loss of function, and is certainly going to be a real problem for this individual. Continuing on with some of the forefoot deformities, with rheumatoid arthritis, we oftentimes see this type of a presentation, chiefly in the forefoot, wherein we'll get a global change to the foot. And we, in addition to have the rheumatoid nodules, we see this structural deviation, the fibular deviation of the digits, and we see as well that these digits are contracted oftentimes with the flexor and extensor contracture, and they're fairly rigid. This is oftentimes a problem because these hammer toes aren't just a nuisance in that they're clawed up digits and they have problems with corns and calluses. The problem comes in that as we take the weight bearing off of these digits, who certainly serve a function in normal gait, we're now placing all the weight, if you would take a look here on the plantar surface of this individual, wherein we're now prone to very prominent metatarsal heads. We're prone to pain and ulceration to those sites as well. We certainly see rheumatoid arthritis much more often in women than we do in men, and the onset for us is generally in the mid-30s to 40s, wherein we see these patients. And with the current treatments that we're looking at with the rheumatoid patients, they're being kept more comfortable and more mobile through the pharmacologic therapies, and it now becomes oftentimes our burden in the podiatry clinic to go ahead and address this surgically to keep these people ambulatory and comfortable and active for their cardiovascular health by avoiding their foot pain and keeping them in proper shoe gear. Another common deformity that we'll see in our patients being gout or podagra. as it's oftentimes called specifically here in the first metatarsal phalangeal joint, this being the sudden onset metabolic disorder with the crystalline deposits, more common in men in the latter years, 50s, 60s, and 70s. And this is something that, again, treating pharmacologically, but sometimes if we catch this fairly late, it becomes a surgical entity where they have so much of a deposition of these gouty crystals that within their joint and about the joint that we're obligated to do some type of surgical procedure to relieve that. Here you can see this type of a case, a rather extreme example. If we'll look actually on the right-hand side first, where we see this large tophaceous deposit, certainly a very suspicious looking mass that upon a good clinical exam and history exam of this patient had a very long history of uncontrolled gout with frequent attacks. This is something that you would open up surgically and see a large amount of this white paste material, and you would see basically erosion of the joint at the metatarsal as well as the digit level. Continuing on with some of the forefoot problems that we see in these individuals, neuromas, or a nerve entrapment as they're oftentimes called, or Morton's neuroma in the foot, is a very frustrating problem for us to treat because this has a soft tissue as well as a bony component to it usually, and sometimes results in us having to treat these rather aggressively and do an actual neurectomy surgically for these patients. Essentially we have here, this is drawn out for you with the blue being the bony structures of the metatarsals and the phalanges, and the red being the intermetatarsal nerve that splits then at the level of the metatarsal heads into the digital branches. And this is oftentimes a very classic presentation of these patients coming into the clinic and saying that they feel this burning, tingling, and sometimes painful numbness between the two opposing surfaces of the digit. And you'll basically take your index and middle finger oftentimes, or thumb and index finger, and squeeze on the top and bottom surface of this space between the metatarsals, and you'll trigger this sharp shooting pain that they'll feel going out into their digits, and oftentimes a warmth. This is something that is most often treated by us with injection therapy. We use the corticosteroids, usually injecting about a cc of lidocaine and a half cc of Kenalog or Celestone Soluspan right into this intermetatarsal space area and going fairly deep with an 1.5-inch needle. That can provide a good amount of relief, but if we haven't addressed the actual structural deformity that's causing this nerve entrapment, or perineural edema as we say a lot of times, because a lot of this is extrinsic to the nerve, then we're going to see almost certain recurrence. So generally these patients are fitted with orthotics to adjust their weight-bearing status and make this into a deformity that hopefully will not recur for these individuals. Looking now at the principle of intrinsic atrophy. This is something, again, we talk about oftentimes in our diabetic patients, but it's something that we face in the geriatric population, wherein we have this natural wasting of the soft tissues as we age. And we can see this visualized here in the hand with the thenar eminence, and then we can see this as well in the foot, both dorsally and plantarly, where you start to visualize the tendons much more. We're just losing this nice supple appearing foot into more of a skin and bone type of an appearance. And this is a problem, particularly on the plantar aspect of the foot, is that, again, as we talked about with the rheumatoid patients, our geriatric population is very likely to this metatarsalgia, or generalized plantar pain throughout the bottom of their foot, usually on the ball of the foot. And this is certainly our weight-bearing, key weight-bearing and pivotal toe-off portion of the foot. And should we lose that natural plantar fat pad, certainly becoming a big problem for these patients. And again, going right back to the beginning of the lecture and sounding silly and simple, is the fact that shoe gear is certainly a very important first step in these individuals, because oftentimes they will come in presenting with, why do I have all this pain in the ball of my foot? And you take a quick glance at their shoes and that quickly answers your question. Looking now at some of the rear foot problems that we address in the podiatry clinic, by far the most common for us would be plantar fasciitis, or formerly really known as heel spur syndrome. We know that the entity is not really caused by a heel spur. It is most often associated with a heel spur, but that just means we're taking the x-rays too late. The individuals start off with primarily a contracture of the plantar fascia. And this fascia, when we look at it, runs all the way from the calcaneus and then comes all the way distally and attaches actually into the digits. So this fascia is a rubber band, if you will, for every step that we take as we're walking on these hardened surfaces. Heel spurs used to be something that we would historically talk about in the podiatry literature, that you would see in, used to be called policeman's heel or waitress heel. And this is an entity that was just a factor of their environment and the fact that these individuals were walking on hard surfaces throughout the day. So plantar fasciitis, with this contracture of the plantar fascia then leading to and causing this spur, because as we all know, Wolff's law tells us that bone is going to grow in reaction to these stresses and these changes in ionic forces, which that stress of the plantar fascia will then focus about this plantar aspect of the calcaneus. So our treatment for plantar fasciitis is again back to basics. We've got to make sure that these people are in proper shoe gear, that they have good foot control. We will treat the acute pain typically, again, with the corticosteroid injection, generally involving 1 to 2 cc's of lidocaine, along with, again, some Celestone Soluspan or a Kenalog, so that you have a combination of short and long-acting cortisone effect. This will take care of the pain usually for about a month. We give that injection from a medial approach into the heel, and this is, the patients often think that we're miracle workers and we've cured them, but then they come back with great disappointment at a month later if they were not properly educated to understand that this is not going to cure their problem. We're addressing their symptoms. So these patients, in addition to a cortisone injection, which can be repeated if necessary at a monthly basis for up to 3 times, is generally our rule, generally receive a non-steroidal anti-inflammatory to again help them with the acute pain. But they'll leave our clinic that day with a low-dye strapping, which is basically an athletic support taping to the bottom of the foot with transversely running segments of cotton-type athletic tape. And this will provide an almost immediate relief or rest to the plantar fascia and give this some sense of offloading its workload so that it can heal. We're never able to fully offload these people unless we put them into a wheelchair. But whatever we can do to take some of the pressure off of that while it's healing is certainly a big help. And we'll do that with the strappings, we'll do that with orthotics, we'll do that with something as simple as a heel raise in someone's shoe to put more weight on their toes than it is on their heel. So a lot of treatments for that, and the stretching and strengthening exercises as well as physical therapy are a big part of our treatment to that as well. And the patients have got to do these exercises at home in the morning and in the evening, preferably for 10 minutes each, particularly to do Achilles stretches, and then we oftentimes tell them to stretch with a bath towel that they'll wrap around the ball of their foot and pull the loose ends towards themselves so that they can get some stretch of the plantar fascia as well as the Achilles tendon. Here you can see some of the recommended stretches that we have. We tell the patients to curl a towel towards them with their toes, as you can see here illustrated for you on this slide. And then if we move to the right, you can see that we're just doing some manual manipulation for this patient that they can do at home, instructing them on toe extension, because as we know, with the fascia attached from the heel to the toes, this will help to stretch that. We move to the bottom left then, we look at the calf and heel stretch that we oftentimes tell our patients to find a stairway on the front of their home or hopefully in their home that will allow them to stretch out this whole Achilles complex as well as the plantar fascia. And then moving to the right, just simply an athletic type of stretch again to the posterior musculature of the foot and leg. Looking here at some photos on the right side, certainly showing a very extreme version of lymphedema. Certainly not the worst that I've seen, but I'm sorry, the left side showing the lymphedema. And this individual, oftentimes of really unexplained origin, will present with one or both of their lower extremities, just almost to a elephantiasis type of a presentation. And this is just really a concern for which we have very little treatment to offer, unfortunately, other than supportive measures with compression and on occasion some anti-inflammatory modalities. If we move to the right, we can see, looking up on the leg in particular, this area showing this hyperpigmentation. This is a post-ulcerative patient. You can see that just from looking at the transverse lines in this individual's foot. This is the compression bandage that was just taken off, in an effort to heal up this site, which is now a closed venous stasis ulcer. And we say that that generally presents to the gaiter aspect of the leg, which is looking at the lower medial third of the leg, right in this particular area. We've all certainly seen that, not uncommon at all. We're getting a bit more progressive with this treatment as well, and we're moving now from the Uniboots into more of the 4-layer compression dressings, such as Pro4, and there are several other that are being marketed through Smith & Nephew and some of the other wound care companies out there. And we're additionally a relatively new product under the name of Apligraph, which is a bioengineered skin, being an epidermal and dermal component, wherein we can actually apply this to the ulcer site, both in the diabetic foot and the venous leg, and seek a rapid progression to healing for these patients. We know that the longer these are open wounds, the more likely they are to receive an infection. This being now just a classic example of an active venous stasis ulcer, again in this typical medial aspect of the ankle or lower leg, with this generalized bogginess around the lesion. You can see the erythema here, not infectious. This is simply just reactive erythema. The body is basically, the tissues are dying here because they have an excess of this venous fluid that is congesting, and this venous waste that is certainly supposed to be carried away by the venous system but is not being properly done. These ulcers almost always heal, and they heal generally within about a month with proper compression. They will, unfortunately though, almost always recur as well. We say there's about a 70% recurrence rate for venous leg ulcers. And the geriatric population, it's an unfortunate situation because we know the key to preventing recurrence of these ulcers is to indeed have them on compression therapy even when they don't have the ulcer. Something as simple as a TED stocking, though, is very difficult for our geriatric population to be able to utilize on a daily basis, and our patients just struggle with the fact that there's no one at home to help support and to help get this stocking on and off each day. And granted, it's not an easy device to place on and place off, because in order to be effective, it has to be quite compressive, upwards in the 20 to 30 millimeter range. Here's some eye-opening photos, along with a rather diligent quote, actually, by George Bernard Shaw of recent, where we talk about some problems in our society. In this portion, like I said, towards the end here, I'd like to focus particularly on the diabetic foot, and we'll get through as much of this as we can, where our society and our healthcare system and our reimbursement system has long been based upon the surgical amputation of these limbs rather than it has been towards prophylactic and preventive care of these extremities. And these are unfortunately just some very extreme examples of what can happen to our patients. We know that the infected diabetic foot wound is really one of the most common, if not the most common, reason for presentation and admission to the hospital in our diabetic population. We know that this equates for upwards of 25% of those admissions in relation to diabetes being foot-related. However, we're doing a very poor job of properly evaluating these wounds in our charts, and this 14% figure study comes from a study out of our institution where we went and did a chart review through 13 healthcare institutions in South Texas, including our own, and found really a very poor ratio of simple documentation of where is this ulcer, how deep is it, what is their vascular status, what is their neurologic status, and what are the other comorbidities associated with this ulcer. So I think that with the NIH as well as the ADA increasing the awareness now of the lower extremity and the risk of limb loss in the diabetic population, we're looking to increase public awareness of prophylactic care and preventive care. Of these unfortunate diabetic amputations, we know that upwards of 70% of them will come back for some form of an amputation, whether it's a digit or their entire leg, within 5 years. So that first amputation is just a real pivot and a real downfall for our diabetic population. We know that upwards of those bilateral amputee patients, upwards of half of them will be dead within 3 years. And 25% of them will never return home and will remain in healthcare institutions. So some rather astonishing numbers, and some numbers that we really should be able to make a difference with, doing a better job on our side as well as involving the patient more in that care. We know that ulcerations are a pivotal reason for limb loss, and these are chiefly two reasons. The first being that this hole in the person's skin is a portal for infection, and the second being that we now have an open wound in this person who has most likely a compromised vascular supply, and now we are going to create critical ischemia because this increased oxygen demand of this wound is not able to be met by the vasculature of this individual. We know there are many risk factors for ulceration. I'm going to go ahead and leave some of this detail for a bit later. But when you look at our former approach to diabetic foot care with this far side cartoon looking at horse hospitals being labeled at the bottom here, and you can see the physicians carrying around their shotguns for the broken legs. This was our antiquated approach towards diabetic foot care not that long ago. And we've come quite a ways in the last 10 years, and we're very proud, as far as San Antonio, to be part of making a difference in this population now. Looking briefly at our classification system that was developed here with Dr. Lavery, Armstrong, and Harkless, this was just published recently in 1996, and the idea of this wound classification system, not that we need more numbers and letters out there to associate with our patients and to document in our chart notes, but the idea was that what was currently in existence for wound classification, particularly for diabetic foot, was really substandard and didn't give us enough information. We wanted to be able to quickly and efficiently communicate this person's limb loss risk, as well as be able to, in some form, have this ulcer classification system give us some indication of what treatment is most likely going to be necessary for this patient, just as many of the other classification systems do. Here you can see a fairly deep wound underneath the first metatarsal phalangeal joint, with the toes being up in this direction, medial aspect of the foot, and here you can see clear exposure right down to the flexor tendon apparatus of the hallux. We know that the deeper these wounds are, particularly those that probe to bone with any type of blunt, sterile surgical probe, or less ideally with a cotton swab, these wounds are very prevalent for osteomyelitis, and we say upwards of 90% of them will have a likelihood for osteomyelitis. And a lot of this work being done by Gail Reiber and others at University of Washington. The ischemia and infection component of these wounds, again, being something that we have to just very carefully evaluate and examine and find out how does this integrate into the ability to treat this wound and the ability to prevent the poor outcome from these wounds. The previous classification systems that were out there really focused on the bottom line, there being the Wagner classification from 1981, widely used in the healthcare system, and if we look at it here on the next slide, you'll see that realistically this system, as far as we're concerned, it's a very good system, and it's certainly a very simple system to approach, but it's just not giving us enough information to help determine some form of treatment for these patients. So if we look here, certainly we know that in a diabetic patient we've got to be concerned with depth. Is it infected, and is it ischemic? And with the Wagner system, these are all really independent factors, and they're classified independent of each other, and we're not able to overlap them. We know that this deep wound, or perhaps this very superficial wound, could certainly have a large component of ischemia. But this is not really addressed by this system, so we wanted to look for something that would still be simple, that would encompass all of this, but would perhaps give us a bit more information. And our system has 4 grades or depth, and it has 4 stages or associated comorbidities. When we look at the grades, fairly simple: 0, 1, 2, and 3. Grade 0 is no ulceration. It's covered, but it's either pre-ulcerative or post-ulcerative. So you've got a callus there, or you have a healed ulcer with some thin atrophic skin covering it. That's still a risk for ulceration, or re-ulceration as it may be, but it's not an ulcer. A grade 1 is full thickness through the skin, grade 2 being down to tendon or capsule, and grade 3 probing down to bone. When we look at the letter now component, A, B, C, D, A is a wound that is well vascularized, not infected, clean wound, as you can see in the picture. B would be an infected wound, C would be a vascularly compromised ischemic wound, and D would be a wound that is both infected and ischemic. If we look at the system now, in a kind of a graphical representation, you can see it really is quite simple. We have, again, the depth coming across here to the top. We have the comorbidities coming now down from top to bottom. And as you can see, as this 0A wound should either present or progress towards a grade 3D wound, this is where we expect our poor outcomes. We know that these patients are and should do very well from this ulceration, and these patients can very much expect an amputation. So this, with our initial exam, can help us to present a good amount of information in these patients. So how is this really going to help us now? As we talked about, we want to be able to predict the rate of amputation and the necessary treatment for these patients. Just real briefly to look at for you in a graphical representation in a validation study that we did for this classification system, you can see that the stage A wounds, or those clean wounds, no matter how deep they were, minimal amputation rate. But then if we move back to B, C, and D, now we're starting to see here's indeed where our amputations are. And just as we followed the graph in the previous slide from 0A being not much of a problem to 3D being a real problem, this slide again helps us to confirm that, with the rather tall bars being all concentrated towards the deep and ischemic infected wounds. This is just another graphic representation of the same information. What we found indeed was that these patients who had infection and ischemia were upwards of 90 times more likely to receive a midfoot or higher amputation. And that's no huge news to anyone. It's common sense to us in healthcare that infection and ischemia are bad and they're going to worsen our outcomes. But for us, this number, as far as 90 times, was rather staggering to learn that. What we found in addition was that, that patients were 11 times more likely to receive, again, a midfoot or higher amputation if their wound simply probed to bone. So again, just giving us information to compare each of these patients. So really it comes down to two simple questions, number one is how deep is the wound, and number two is the wound infected, ischemic, or both? And we have then achieved our classification system. Now that's not to say that our note shouldn't reflect a whole lot more as far as the color and nature of this wound, but we haven't found any of those other factors as far as quality of the drainage or the etiology of the ulceration to play as much of a role in the outcomes of these patients as the other factors mentioned did. And if we have to stick to an absolute 3:15 stop time, then I would go ahead and make this my last slide, unless because I have also the diabetic foot risk classification system on slide if we have time, but otherwise this will be a very good stopping point to at least look in, see if there are any questions thus far. This is just a little bit of, again, comic relief. This is a pawn shop that's about a mile away from our $28 million Texas Diabetes Institute, and I always just say God bless Texas whenever I see this sign, because you'd only find this sign in Texas, where the reward is not for leading to the arrest of, or leading to the capture of, or leading to the recovery of merchandise. The reward is for killing the thief and bring him back in, and you'll get your $10,000. So that's only in Texas that I think we'd see that sign, and I had to turn the truck around and take a picture of that for you all on the camera just to capture that. But I hope that we conveyed some of the basic information to you. I didn't want to focus too much on diabetes and keep it more general to structural and dermatologic skin problems that we saw in the earlier slides. But diabetes certainly being, at least in San Antonio for us, our key geriatric challenge that we face in the trenches on a daily basis. And I think we're making a real difference, and certainly our technology is coming a long way. We're working a lot with some of the growth factors for these diabetic wounds. We're working a lot with some of the more precise ways to offload these diabetic wounds from their pressure and keep them in their walking boots and special made shoes and custom molded insoles. And I think we're really making a difference, and we hope to continue that. So I would open it up for any questions.
What about the growth factors? What have you found so far in the stuff like regranics?
Very, very good question in regards to growth factors. Regranics is a product that is a recombinant platelet-derived growth factor. It comes in a 15-gram tube at a price of approximately $300 per tube. Marketed by OrthoMcNeil Pharmaceuticals. It's the first of its kind to be a true growth factor. A lot of wound care products out there claim to be a growth factor, but this is the first true growth factor that was developed. Its efficacy has been disappointing in clinical aspects to a lot of people, but I feel strongly that that's from poor wound selection. Its current only indication per the FDA is for diabetic foot ulcers, so we have a good amount of experience with it in the clinic. And I can tell you that particularly where we have used it is in a post-surgical wound, someone who we know is diabetic, has poor vascularity and poor wound healing ability. We'll use this as an adjunct to our daily wound care. And we'll see, for instance, someone who had a partial ray amputation and they left the hospital with an open wound because it was still draining or still not able to be closed, or maybe there's just too much of a space there to be closed, primarily with suture. We'll put a lot of these patients on Regranex, and we have noticed a marked decrease in the time that this wound is open. And we're getting even more progressive now, using Regranex for, say, 2 to 3 weeks to granulate up this wound, and then we'll apply Apligraf, being the bioengineered skin, as almost in the form of a split-thickness skin graft, or sometimes in substitute to a split-thickness skin graft, and we'll realize immediate closure of this wound in approximately 4 to 6 weeks with Apligraf. So we're looking, and the expense issue with Regranex, again, I think in the right selected wound, it's fully worth it. And
what you're talking about is surgical wounds, but what about diabetic wounds?
Yeah, and this being surgical wounds in our diabetic population who have a slow wound healing ability. The diabetic plantar wounds, the Regranex to me still has a role in the clean wound as long as you properly use offloading in combination with that. Because we know that we could put anything in the world that we want on this wound. If we don't take the pressure off of it, they're never going to heal. So yes, we do use Regranex on the plantar neuropathic or neuroischemic ulcers, oftentimes under the heel, under the metatarsal heads, under the big toe. We'll use it. But one of my favorite uses for Regranex is in the post-surgical defect. That's where I found it really to do well. So.
What are your absolute criteria when you know the patient is definitely going to need the amputation with this ischemic neuropathic wound or ulcers with or without osteomyelitis and diabetics? What are the things you look at as soon as you see the patient which will tell you that this patient probably is going to be better off with the amputation than this conservative therapy for 6 months or a year or more?
That's an excellent question. Looking at, can they hear those questions, or should I repeat those? Okay. The question in regards to when do we decide to go to a primary amputation on a diabetic patient versus 6, 8, 10, 12 months of possibly some initial surgery and then dealing with an open wound for that length of time. Excellent, excellent question. It's something we struggle with on a daily basis. I think we've come to a pretty good sense now of the fact that we as podiatry, and one of our chief residents said it best in Grand Rounds just not more than a year ago. I distinctly remember the statement that below-knee amputation is not a failure. And we in podiatry, oftentimes, we lose the foot, we've failed. It's ingrained in our mind. And so it's a very good point that you make, that there are cases, particularly in ischemic wounds, where it's time to proceed to a primary amputation and shorten this person's course in the hospital, and perhaps if they're a candidate to fit them with a prosthetic, they will be back and ambulatory and home much quicker than if we tried to deal with a partial foot amputation or an ankle amputation, or where we tried to take this. And we sometimes, I think, just get greedy, and we don't want to give up on these patients, and we just want to do anything and everything we can, but sometimes that primary below-knee amputation is the most functional and humanitarian thing we could do for the patient. Specific factors to judge that: number one, ischemia. Again, if they are non-bypassable, our vascular surgery service here is top-notch with Dr. Sykes and Smilanich and Turkosisian. Most of our patients with diabetic wounds who have any sign of ischemia receive non-invasive exams, and then they will, from those, proceed on to an angiogram. And if there is a vessel to bypass into, we will try an aggressive distal bypass, going into some of the vessels below the ankle, and not just bypassing to the fem-pop or that level, coming much lower. And that has certainly increased our limb salvage rate tremendously. And several studies in the literature document centers, wound care centers, that have an active distal bypass service, a vascular surgery service with trained surgeons that are doing these distal bypasses, versus centers that do not have this as a service, and their lowest they bypass is perhaps to the popliteal. Their amputation rates are much higher. at those centers that do not have vascular surgery. So infection and ischemia still being our two big guide points towards amputation risk. We say that ischemia is not a very high risk for ulceration. Ischemia doesn't naturally cause an ulcer. It'll cause gangrene, but it won't cause that neuropathic pressure ulcer that we see on the bottom of the foot. But they develop that from their neuropathy. But should they develop that ulcer, then the ischemia comes in and that causes the amputation. The ulcer itself might not have been a limb-threatening ulcer, but the combined ischemia makes that a limb-threatening situation. So,
is there a benefit of doing just sometimes with half-foot?
yes. Question being, is there a benefit to do a half-foot or mid-foot amputations? Most of our amputations we do digit amputations, we do partial ray amputations, which takes the digit and the metatarsal head to facilitate closure of that tissue. And then one of our very common amputations is a transmetatarsal amputation level. I distinctly remember someone from my training saying, crude, but if I ever become diabetic, I want a transmetatarsal amputation, because that is a very functional level of an amputation. The transmetatarsal keeps a good parabola. It keeps things at a good level. These patients can be easily fitted with a shoe. It's something that they are completely ambulatory from, and the recovery period is fairly brief. So we do a lot of midfoot amputations. I, of recent, have had several show parts amputations where we leave simply the calcaneus and talus, and all of the rest of the foot is gone. That is still a functional amputation. Oftentimes, though, the only reason I'll do that is if they've had a below-knee amputation on the other side, and we're getting backed into the corner of having to do a BK on the second side. I'll do anything I can to try and save something to transfer on. So in those cases, I'll save a show parts amputation. A lot of midfoot amputations with a good success rate. There's increasing documentation and literature to do tendon transfers along with those amputations, so that if we've taken away all the tendons that naturally balance out the foot, if we amputate at the midfoot, the foot will go into a natural calcaneal valgus or a varus rotation, oftentimes more commonly. So we'll do sometimes a medial to lateral tendon transfer to try and balance that back out and balance the foot. So that's most of our work is midfoot amputations. Sure. Good questions. Any other questions at all? Good. Thank you.
Where is this latest article you talked about published?
The wound classification system? Actually, I have a couple cards that have the literature on. If you want, I can give that to you. It's Journal of Foot and Ankle Surgery, I believe, is where it was. This is just a nice little, and actually right at the bottom here is the reference. So it's Diabetes Care and Journal of Foot and Ankle Surgery are the two references. Sure.